All right, so continue on from where we were. So let's move on to another disorder, and this time we'll stick with women. And this is the pain disorder, the two categories that were merged, and it's called genitopelvic pain penetration disorder. Again, it's a little bit of a tongue twister, but here's the definition in the DSM for women. Persistent or recurrent difficulties for at least 6 months with one or more of the following. And by the way, for all of these dysfunctions, you have to have 6 months in 6 months duration in order to get a diagnosis. If it happens once, you can't get a diagnosis. Okay, if it happens for 2 months, you can't get a diagnosis. It has to have a duration of 6 months. So here are the criteria for women. Inability to have vaginal intercourse or penetration, or marked vulvovaginal or pelvic pain during vaginal intercourse penetration attempts. So you have pain when you try it, or you can't have penetration, or you have marked fear or anxiety about vulvovaginal or pelvic pain. So you're scared of it, or you have tightening of the pelvic floor muscles during attempted penetration. So any of those things, you only need one, but any of those things can get you a diagnosis of genitopelvic pain. This is a cognitive model of what happens. You don't need to memorize this, but I sort of like it. And I have talked about this before when I was introducing CBT to you. And I've talked about the treatment, how the treatment for this disorder, what we used to call vaginismus, is much like the treatment of a phobia. And I think it works very much like a phobia. And here is, you can see if I can make this work here. That a lot of times what they think is that it starts off with some sort of negative emotions. For example, maybe you've had an extremely conservative religious upbringing, and so you're already sort of negative about sex. You avoid penetration. That makes you tense up your pelvic floor, and then you get excited because you start getting sexual. But when you try it, then because you're tense already, because you have these negative expectations, you have pain. The pain comes from being tensed up. And then there's some thinking about that, like, oh no, this is awful, it's going to happen again and again, or something's wrong with me. And then this makes you hypervigilant about your body, so you notice every single sensation in your vagina. This model includes that the partner may also, their thoughts may influence you as well, that they may have some hostility or anger, or they may have some catastrophic thinking, like, this is never going to work, we're never going to have normal sex, sort of thing. But all in all, it's very much, we can treat it like a fear response. This is the interesting thing, it's almost never physiological. So if you look at treatment of it, I'm going to show you the treatment. I'm going to remind you about it because we've seen this before. But it's pure CBT. Oh, I guess I can't open this. Here you have, this is just an Amazon page. Oops, this is not the one I was looking for. An Amazon page of vaginal dilators that you can get. Let's see if I can see them here. I had them. I'm just struggling with the screen. Oh, here we go. Here's some Intimate Rose Dilator Small Pack. $79. They can really charge you. Now here's only 31. Much better. But essentially, the idea is just like the treatment of a phobia, that you start off with relaxation and then gradually introduce something in the vagina, starting small, getting bigger. So that is the treatment, again, just like treatment of a phobia. If I move on to male people, genitopelvic pain or penetration disorder in men is much more likely to have a biological etiology. And it can be stuff, it's actually quite rare, but it could be something like somebody's had a surgery for a hernia or for hemorrhoids, and they have sex before when their doctor says, you should wait 2 weeks, but they have sex before, that can cause pain. It can also be a symptom of a genitourinary tract infection, or it can be a sign that there's a herpes sore forming. Maybe you can't see it yet, but it's on its way. So on to the last topic, which is sex addiction. And these are 3 people who've said, at least in their life, that they have a sex addiction. And what I want to say about this is, first of all, something that's very important to know is it's not in the DSM-5. Researchers who researched this, and they looked at correlates of it and how just a variety of sort of statistical things that determine whether or not something should be a disorder, and they just didn't feel it rose to the level of a disorder. Now, remember, it's in the ICD, you have you do have hypersexuality in the ICD. So it's a disorder in Europe, but not in the States. You can get an actual diagnosis. So whenever I talk about this, one thing I find, a lot of times there's a lot of thoughts and feelings about this from both sides of the aisle, from people who are more conservative and from people who are more sex positive. A lot of times people who are conservative say that's just an excuse. You're just excusing bad behavior. And people in the sex positive aisle say this is completely cultural, and you should be able to have as much sex as you want and not have it be labeled that something's wrong with it. Remember, we talked about how reading or helping people, we wouldn't get an addiction diagnosis. I fall somewhere in between. I think that people who should be able to have as much sex as they want, as long as it's not harming them or their family, or as long as it's not, it's something they've agreed on in their relationship. But I think most of these people here, I'm not sure about Tiger Woods as much, but most of them, they've really lost control of it. And I have met people in my practice, both in private practice and in the hospital, who, they had genuine distress. They really felt like they couldn't control this. It was much like another kind of addiction like alcohol. They said things like, I tried to stop, but I couldn't. It's affecting my life. I'm not going to work. And when I should be, and I think those people should be able to get help. Now, the premier name of this in the States, and he actually has a place in Texas, an inpatient place that I've sent people before, but his name is Patrick CARNES. We'll get to him. There is controversy about whether it's a disorder. And again, in ICD, it's called I call it hypersexuality, but it's called excessive sexual drive. And by the way, it's for males, it's called satiriosis, and for females, it's called, big surprise, nymphomania. Again, some sex positive people argue that its very existence is sex negative, and we shouldn't even categorize it as a disorder. Here are the symptoms. Now, these do not appear in the DSM, but these are the symptoms he talks about with his research. And I'm not going to go over each and every one of these, but I want you to know, I want to highlight that they're very much like the symptoms you see in the DSM for substance use disorder and for the only behavioral addiction in the DSM, which is what? It's gambling. So there's symptoms like this: recurrent failure, a pattern of failure to resist impulses to engage in acts of sex. Again, that you try to resist, you tell yourself, I'm not going to, and then you do. So it's that lack of control. Similarly, frequently engaging in those behaviors to a greater extent or over a longer period of time than intended. So you meant to do something and you ended up doing something else. Again, lack of control, persistent desire or unsuccessful efforts to stop, reduce, or control these behaviors. You see the same kind of wording in the substance use chapter. Inordinate amount of time spent in obtaining sex, being sexual, or recovering from a sexual experience. So you find yourself online a lot, looking at porn, for hours, or maybe obtaining a sex worker. Preoccupation, it's in your mind all the time. And by the way, I treat a few people right now who have similar problems. Somebody that has a webcam, sex webcam kind of issue. And they talk very much about how I want to stop and I can't seem to. And, you know, when I get bored, I'm in the library working on something and I find myself going to my phone and looking to see who's online to see who I can have internet sex with. So this sort of preoccupation is something you really do see. Just to tell you about a specific case, again, everything's been changed to this. Somebody comes into the hospital. I did their assessment. I also was their group therapist. And let's just say they're a 34-year-old male, somebody who's a physician, so somebody who's pretty high functioning and quite intelligent, hospitalized for initially for a methamphetamine dependence, married to a woman. But upon talking to him, what you find out is that the meth is inextricably linked to some sexual behaviors. What he does, now, when we had our sex tour, you saw that there's a lot of times in cities there'll be a cruising park. The interesting things about these cruising parks is often they're not men who identify as gay in these cruising parks, but they're men who hook up and have same-sex sex, usually somewhat anonymously. But he would go to his local cruising park and he would bottom, he would be the penetratee, but every time he would use meth first. It was this sort of combination, use meth and get high and then have sex. He contracted HIV. His wife didn't know about any of this, but because he was using meth, he was also engaging in really risky sex, so penetrative sex without a condom. Really interesting guy. He was in a group therapy that I had with a guy who was gay, who said, "Come on, man, you must be gay. You must like it." And he says, "I really don't think I am. I only want to do this when I'm using meth. I'm attracted to women. I don't know why." And for him, I sort of believed him. It seemed to be some sort of unconscious, self-destructive behavior that he would engage in that was, maybe he was bisexual, but he seemed to be happily married, and it was just something he had a lot of other sort of self-destructive kinds of behaviors. This is a guy who didn't show up. Think about it impacted his functioning at home. He didn't show up to do some surgeries that he was supposed to do because he was out doing this thing. So, it impacted his functioning at work. Um, he was quite a delight to treat. He was once he got sober, was he he was really good with the other patients, and then he would sort of confront them and in a helpful way in group therapy. But he was sent on to CARNES's place because we decided he actually had primarily was more of a sex addiction than a methamphetamine dependence. That was the more primary issue. And this is a guy who, if he never used meth, would never probably have this sex addiction. So we got him clean from the meth, got him involved in some 12 steps and some psychotherapy. So this sort of thing really does happen. I can't really get in the camp where I say, no, this isn't a disorder, because people really will show up at your doorstep and complain about this, and we have to have a way to talk about it. So I know this is a really long series lecture. Thanks for sticking around, and I'm going to go ahead and stop now. If you have questions, email them to me, and I'll send them. I'll answer them in another video.